Hi everyone, good afternoon. I bring greetings from the Telangana chapter of Obstetrics and Gynecology, the TCOGS, on behalf of Dr. Narasimha Reddy, our president, and myself, the secretary. And thank you, friends, for joining us today. Today is really a star-studded webinar of TCOGS. We are going to discuss the medical management of endometriosis and the most awaited panel discussion, life of an obstetrician during the COVID era. I'm sure that all of you are very eager to know how the life of an obstetrician has changed during the COVID era, right? So friends, we are very happy to have with us a galaxy of speakers. Oh, I have to tell you all, we obstetricians are used to emergencies and we know how we can actually live up to an emergency. So I'm sure all of us are doing the same with this COVID pandemic. We had a cyclone which hit Bengal, and our dear friend Bhaskar couldn't join us on this webinar because there was a complete shutdown of the internet, and we obstetricians are not worried. Just 5 minutes notice, and our dear Professor Narendra Malhotra sir, our past president, and if I keep talking about Narendra Malhotra sir, there's nothing with more anybody can talk. Sir is a professor in Dubrovnik. He's the most favorite past president of Foxy. He's the past president of ISPAT. He was the vice president of SAFOG, member of the FIGO Guideline Committee, is the dean of the ICMU, director of Ian Donald School of Ultrasound, national technical advisor for Foxy GOI, MacArthur Foundation, EMOC course, the managing director of Global Rainbow Healthcare Agra, which is now taking care of lot of emergencies, COVID and non-COVID in Agra, which has become the epicenter of infection. He has been practicing obstetric gynecology in Agra, and we all know the pair, the Malhotra pair, my dear friend Jaideep Malhotra and Narendra Malhotra sir, who are there at every meeting. And I think this is the first time in their 30 years of plus married life, I think they have stayed together in one place in Agra thanks to the pandemic. Otherwise, they're always trotting around the globe and India. And he has got so many publications, so many guest lectures. He's the most important is the chairman of the Smriti NGO. And he's been the editor of series of step-by-step book. And he has even revised the Jeff Cott's textbook of gynecology. The most important is 5 minutes notice, and he has actually agreed to give this lecture on medical management of endometriosis. Thank you very much, Narendra Malhotra sir, and a warm welcome to the webinar today. And let me introduce my other friends. Let's hope that we will be able to catch up. Dr. Bhaskar Pal, who, if internet permits, will join us on the panel. Dr. Bhaskar Pal is a senior consultant gynecologist at Apollo, Kolkata. He is the honorary general secretary of the IAGE, past vice president of Foxy, president-elect of Bengal Obstetric Gynec Society, and one of the very dear friends of Hyderabad and Telangana. Yes, we have with us our own Dr. Narasimha Reddy sir. Everyone in Telangana, Andhra Pradesh know Narasimha Reddy sir for his very simple way of looking at things. He's been practicing gynecology in Warangal, and I'm very happy to share that I am from Warangal too. I was born in Warangal. With experience of more than 32 years, he has even worked as a professor of OB-GYN at PIMS Karimnagar. He's the president of Telangana chapter of OB-GYN. And above it, let me tell you friends, he is one person who is dedicated to the women's health, and he has been practicing in the peripheral center with amidst all shortcomings, anything and everything. He never says not possible, and he takes care of the patient. Thank you, Dr. Narasimha Reddy sir, for joining us.
Thank you.
We have with us next, yes, this is a wonderful lady. I'm going to introduce you, my friends, Dr. G. Mahalakshmi. Dr. Mahalakshmi is a professor and HOD of the Obstetric and Gynec Department of Gandhi Medical College Hospital at Secunderabad, Telangana. Now, Gandhi Medical College has been in the center of news all over the state and the country because it was the first COVID hospital of Telangana, and they have been doing fantastic work in the COVID era, and they have been actually putting their life in the forefront, not worried about anything, but only with the concern of trying to take care of women's health. We are very proud and thankful to Dr. Mahalakshmi and the whole team at Gandhi Medical College. She did her PG from Kurnool Medical College, and now we are very happy to have her here. She's been the recipient of the National Mahila Ratna Award and Dr. APJ Abdul Kalam Education Excellence Awards. Thank you, Dr. Mahalakshmi, for being with us. Now, friends, I have the great pleasure of introducing my dear friend, Dr. T. Vindhya, who is a consultant at Apollo Hospital, Hyderabad. Vindhya is the president of Obstetrician Society of Hyderabad. She is the ICOG Governing Council member. She's been the secretary of South Zone convener of the ISOPAB. She's been the joint organizing secretary of the AICOG 2011, which was a landmark conference. And Vindhya has been a very strong pillar during my growth to go on to be the Foxy president-elect. Thank you, Vindhya. And she's a member of the executive member of Vijay Foundation Trust, which is an NGO for women and children at Kadapa. Next, friends, we have with us our own Dr. Aruna Suman. Aruna is an associate professor at Usmania Medical College, the MGMH Petlapurj Medical Hospital, and she's a vice president of Obstetrician Society of Hyderabad. She was the secretary of Hyderabad Society. She's been the signal review member of the Indian Pharmacopoeia. And let me tell you, Aruna Suman is a real darling of the whole of Obstetrician Society and the managing committee. You tell her anything and she's always ready with a smile. She will never say no. And that gives you a positivity that we will be able to do anything and everything. Thank you, Aruna, for joining us. And she's from one of the most busiest medical college hospitals of Hyderabad. Next, I have the pleasure of introducing my dear friend, Dr. Krishna Kumari. Krishna Kumari needs no introduction. She's always called as the scientific madam. I always call her the scientific madam. She's been the Lazarus Gold Medal winner of Vizag, and she's a professor and medical superintendent at the Apollo Medical College, Hyderabad, and a consultant at the Medicover Hospital. She was the president of Obstetrician Society of Hyderabad 2017 to 19, governing council member of the ICOG, vice president of the TCOG, and the most important is she's been the scientific chairperson for all our conferences. Every year, Hyderabad Society has the unique opportunity of hosting conferences, and Krishna is our scientific chairperson. And welcome, Krishna, and thank you for joining us. And let me tell you, the past 2 months in the private medical college, she has dedicated herself to know and learn about COVID to make all the protocols at private medical colleges. So she's going to share her experience with us. Next, we have with us, friends. Yes, this is a very important person whom I'm going to introduce you, our own star attraction, our guest faculty, Dr. Murali Krishna Nelapatla. Dr. Murali Krishna is an anesthetist at the Rotherham NHS Foundation in Rotherham in Yorkshire. He has been an anesthetist in Southern Africa, Lesotho for 4 years before he went on to the UK to join the NHS. In the past 20 years, he has anesthetized cases for trauma, emergency, obstetrics and gynecology, ENT, pediatrics, and worked in the intensive care unit. He's got many skills. And friends, let me tell you, Murali Krishna has been working very tirelessly in the COVID era in the NHS, and he's going to share his experience of working in the COVID unit in UK. And I shall tell you more about Murali Krishna when we actually go to the panel. I think you'll be in for a surprise. You'll be hearing some very nice things about Murali Krishna, and that will give you a lot of positivity in this time of pandemic. And friends, most important than everything else, I have to tell you, Murali is my very dear friend from medical college. We have been friends from the MBBS days, and in India, his house is just 2 roads away from my house. So it's lovely to have you, Murali, with us today. Welcome to our webinar of Telangana chapter. So friends, we have introduced everyone, and now we shall start the webinar. Before we start on the webinar, I think we need to thank our educational partners. We need to thank the Bharat Serum and Vaccines Limited. I hope they all also are putting in a lot of effort to see that the COVID vaccine is out soon so that we get out of this pandemic as soon as possible. And they're trying to do their bit by saying we need to bridge Bharat. Now, we do understand that though the pandemic has kept us apart, I think it's 3 months we have not traveled. It's 2 months we have not traveled is history in any of us who are working in Foxy. And yet we are connected, yet we are busy. So that is what all about bridging together people, and thanks to the technology which we are moved in. So friends, warm welcome. Shall we have a small video session? Shall we have that? You said you wanted to put a video. Yes.
Madam, please proceed with the program.
Yes. So friends, let's start the program. Dr. Narendra Malhotra sir is going to talk on the medical management of endometriosis. So sir, the screen is all yours.
Yeah. Thank you very much, Dr. Shanta, for the kind words of introduction and for inviting me to this webinar. I'll try to cover this huge topic as quickly as I can, and we'll take a lot of questions. So all this is available in the Foxy Focus, which we made in 2018 in Dr. Jaideep's time. And you can get that on Foxy website, and you can, if you've not got a copy, you can ask for a copy from Foxy. Now here is a scenario which affects 1 in almost 15 women of reproductive age group, cause not known, not clear how it can be prevented, not known how to predict the development of this disease, no simple test, even on operation the diagnosis is mostly an educated guess, and there are 4 different options, none of them is better. It's not COVID, it's endometriosis. Welcome to the world of endometriosis, which in India has now caught up with the whole world as the incidence of about 25%. 1 in 10 women have endometriosis during their reproductive age group. So it's a vast condition, and every woman who comes to you with pelvic pain, endometriosis, think endometriosis. It's a very complex and challenging and elusive disease. So we will try to summarize the medical management of endometriosis, which is an enigmatic disease and an epiphenomena, and so difficult to treat epiphenomena, as you know. So how do we define it? It's a non-neoplastic growth of the endometrium outside the uterus, which is similar to the endometrium and similar as invoicing. And Simpson's theory still holds good, and it is said that the retrograde menstruation is what is responsible, and the blood goes back, but not all women develop endometriosis because of their immunity. So there is an immune theory. So these cells go in, and then they will cause adhesion, growth, progression, and respond to the woman's hormones and start growing there. So these cells are the antigen, and this reaches through the patent tubes, and they will sit on the peritoneum and stimulate CD4 and helper cells. So all these helper cells attack these cells because they are antigen, and then cause an inflammatory reaction which causes blood vessels to grow and which further causes adhesions and pain. So now why this is important, I put this slide, is important to understand is because your drug treatment is going to be targeted against inflammation, against immune response, against the hormones, and that's how we have to understand why it happens. Then we also have to understand that these cells, eutopic endometrium, normal endometrium, responds to estrogen and then progesterone and menstruates. But when this endometrium is retrograde menstruation and it reaches here, it causes vascular lymphatic circulation stem cells and the immune cells here, and it invades and causes stress, inflammation, and endometriosis. Now this eutopic endometrium, ectopic endometrium, which was eutopic inside, now it has become ectopic. The response may be sometimes, and this response depends on the progesterone receptors. Now in a healthy endometrium, we have 2 types of progesterone receptors, PRAB PRA and B. So B receptors are more in the healthy endometrium. And when the progesterone activates the B receptors, they cause proliferation, destigmatization, apoptosis, anti-inflammatory and angiogenic effect. Cures the disease, or if it is, or causes menstruation. Now, when this endometrium has come outside, it is the A receptors of the progesterone become more prolonged. So the cell proliferation is increased, the destigmatization does not happen, apoptosis is reduced, anti-inflammatory effect of progesterone is reduced, and that is why a lot of pain and bleeding and all that occur. So our disease has to be or a drug has to sometimes attack the progesterone A receptors. So this is what happens with all of the theories, and it leads to inflammation, and this is very interesting to know. Now, another thing very important for us to understand is the delay of diagnosis and the treatment. This is very important because this delay causes permanent damage to women. Now, when the symptoms actually start, the women bear it as menstrual pain. And the first consultation, it is seen, comes after 1 year. And then finally, there is a delay of another 6 years before they reach a specialist who puts in a laparoscope and makes a diagnosis. So there is an average delay of 7 years from the first visit to the GP to the diagnosis of endometriosis. That's why we have to educate our GPs and our normal gynecs to diagnose or think endometrium. Once you think endometrium, we'll diagnose it. Various diagnostic methods, I'm not going to go into the detail. It's the imaging technology which is most important. The markers are not important. These girls and women will present to us with pain, infertility, and pelvic mass. It is actually not a disease. It's an epiphenomena. It's like a benign cancer. And how does anyone treat an epiphenomena of benign cancer? That is the enigma. And you see, if you go on Google and search endometriosis women, you'll see such painful faces which they have put, and they don't know what to do from one day to the other. There is a timeline on what endometriosis had, and that is very confusing to all of us, because there is always going to be a debate between surgical and medical management, and there are no yet clear-cut guidelines, even from ASRM, RCOG, SOGC. As the time evolves, a new guideline comes every day or every year. Now we have to plan the treatment in various groups. We will get girls, we will get infertile patients, we get fertile patients who have already completed family with mild, moderate, severe disease. We'll get treated patients who are recurring, and we'll get rectovaginal endometriosis, and we'll also get pregnancy with endometriosis. Because see, the pregnancy progesterone, we used to think patient gets pregnant, endometrium will be cured. This endometrium is responsive to the B receptors, and they are not there in pregnancy. So pregnancy actually is not a treatment for endometrium because that progesterone does not help. So we will target a treatment for pain. I will not talk on infertility in ART. We'll target something on what recurrence and adolescence. So when someone has got the mic on, can we? Yeah. So when we talk of pain, we will do NSAIDs, OCPs, androgenic agents, progestogens, GnRH analogs, which form an important part, antiprogestogens, which are now new, levonorgestrel IUCD, and some newer experimental drugs, which I'll quickly show you one slide on each one of them. So our first line of treatment after the painkillers don't work with NSAIDs is the combined oral pills, or now the newer oral progestogen, Dynogest, because we want to suppress the estrogen progesterone of the ovary. So we need to suppress it. So we can do it with OCP, we can do it with GnRH analogs, we can do it with oral progesterones, and we can do it with antiprogestogens. The second line was the GnRH agonist and danazol. GnRH agonist depot preparation every 3 months. You can get 3 monthly or every monthly. But you have to be careful, which I'll just show you a little bit. Now, how do they work? They will all suppress the hypothalamic pituitary ovarian axis, and they will cause local effects also of anti-inflammatory or anti-angiogenic. And the newer drugs now are only being made for anti-angiogenic, anti-inflammatory and anti-immune drugs. So those are the newer drugs. OCP is any OCP with a very less estradiol, and any progesterone can be used in it. The OCPs will give you treatment for 6 months, very good treatment, pelvic pain relief, but then it comes back. And when you stop it, it comes back within 6 months. So there are limitations. Danazol or modified testosterone, please never use danazol now. Danazol is not to be used in women for any indication because it causes permanent hoarseness of voice. And we don't want our women to be with hoarse voice. We want women to be with very sweet voice. And we don't want women to have facial hair. So this will cause permanent damage to women's throat and the facial hair. Now, GnRH agonist, very good for short-term, severe, acute, causes amenorrhea, causes anovulation, but cannot be used more than 6 months because you have a risk of osteopenia. So use it for 6 months, give an add-back therapy, use it again for 6 months, where patients can take it monthly or 3 monthly injections. Dynogest is a new drug, and Dynogest will act on the PRP receptors and also as a local effect. So that would be. So before giving Dynogest or any medical treatment, a lot of people argue that you should have a surgical diagnosis. Now it is believed that you do not need a surgical diagnosis by various guidelines, and you can start straight away with medical treatment and judge the response, if they respond or not. So the goals of management is that we want to treat the symptoms, we want to make a diagnosis because they get treated. So your first line would be medical or surgical. If it is an endometrioma or severe disease, surgical. If it is fertility enhancing surgeries, and we will do that. So let's see the algorithm we'll follow. So administration of progesterone alone as therapy in suspected endometriosis, OCP if it fails, laparoscopy. Medical treatment, try Dynogest, try no danazol at all, try GnRH analogs, depo-progesterone, and IUS. All the ESHRE guidelines, the World Endometriosis Society guidelines, all would say or talk on this. So Dynogest is because it works on both the normal endometrium and the ectopic endometrium. So it reduces pain dramatically, just as good as GnRH analogs. But analogs would be your first line if there is a severe disease and acute disease. I am not going to go into the details of danazol. It's just that it is anti-inflammatory, so it blocks the prostaglandin pathway and it blocks the aromatase pathway, and that is why it causes anovulation and amenorrhea also. Estrogen, yes, the estrogen, the endometrium will proliferate. So we don't want to give too much estrogen. So low dose estrogen. So that the estrogen has to be avoided, and anti-estrogenic drugs will work here. So there is letrozole and mifepristone and the others which are coming in, which I'll just touch as one thing. So estradiol, you have an estrogen threshold here which is required. This much is required for bone loss, preventing bone loss. So you need a drug which will not reduce the estrogen from the threshold and will act only on the progesterone receptors. So that is where the Dynogest scores over all the other drugs. Okay, all the others will cause hypoestrogenic states. This we have gone through. So let's summarize the treatment. So anti-inflammatory, GnRH analogs, agonists, OCPs, anti-angiogenic progesterone antagonist, estrogen receptor beta ligand blockers, PERMs, and statins, and some which you can use. The newer drug which is coming very soon is LX4. It's anti-inflammatory, RU486 and sperms, TNF alpha inhibitors, anti-angiogenesis drug, and we already have aromatase inhibitors or letrozole, which also can be used. Mifepristone also can be used in the dose of 50 milligram for 6 months, and this will cause the symptoms to disappear. But then the side effects are always there. And letrozole, of course, still in research stage, but a lot of us still use a lot of letrozole also. Progesterone is no doubt, you can use any of the progesterone except the androgenic progesterones. And analogs is what is very important for the acute. So you have goserelin, you have leuprolide, you have triptoline. Leuprolide is good enough because goserelin is very expensive. And you have 3 months depot injections also available. Be careful of osteopenia, be careful of menopausal side effects. So you can give an add back estrogen and with medroxyprogesterone acetate, or you can give a break after 6 months for a couple of, because the treatment when you stop, it will work for another 3 or 4 months, and then you can restart the treatment. Danazol not to be used Gestanon is there in OCPs now, so it can be added there. If there is adenomyosis and severe pain, then levonorgestrel IUCD works much better. All the other treatments like acupuncture, pain relief, for pain relief, Chinese medicine, all that can be tried, have a very good psychological effects. So hit and miss management is going to be there. And it's not a one-person disease. Please, we must understand, you must have a teamwork to talk to when you have a pelvic pain patient, chronic pelvic pain, a gynecologist, surgical team, pain specialist, psychotherapists, counselors, nurses, nutritionists, all should sit together, discuss the case, and then chart out a treatment for it. Expected management, there is no role. So it is difficult to understand cancer. It's more difficult to understand a benign cancer, and it's impossible to understand an epiphenomena. And Sir William Osler said, which still holds good, he who knows endometriosis knows gynecology. For me, endometriosis is still an enigma, and I'm learning every day in and out. Thank you very much for giving me this chance. Thank you from the city of Taj, and I greet you, and I don't know when I would welcome you again to Agra when this COVID times, when good times come again. अच्छे दिन आएंगे, जरूर आएंगे. You're muted. Shanta, put on your mic.
Thank you, sir, for the wonderful presentation. We have to say that, as usual, your presentation is too good. And yes, you did say endometriosis is an enigma. So at least the women are not an enigma to you. So that itself is a positive aspect. And I'm sure after this COVID, where everyone is locked down inside now, the statement of women being an enigma is going to disappear, and it's only going to be these diseases which are going to be an enigma. Thank you very much.
So on Netflix right now, I'm watching the Grand Hotel. It's a lovely serial. And this woman, after committing some murders, then she starts getting insomnia and pelvic pain. And the psychiatrist, it's a story of 1900s. Oh. And that a psychiatrist comes and says, you have hysteria. Because you are an enigma, because we cannot understand your pelvic pain. Probably the endometriosis got triggered off by her stress.
Yes. So I think that's the reason why we actually put endometriosis, because the stress of lockdown has definitely going to contribute to a lot of diseases, which are all the chronic problems which are going to come out in the coming months. So that people don't forget about the routine problems. That's the reason we thought we should touch upon this aspect of the endometriosis. In fact, what I wanted to actually tell you all is, you all understand that in the COVID era, everyone has become an specialist in COVID, right? So suddenly we are all, I'm just trying to share my, 1 second.
Open your presentation, yes.
Yeah.
That's it.
Then let me see the.
Madam, slideshow.
I know that is getting hidden by the. I am going to make it. Slideshow.
You can do it with the down one. There is another signal down, full slide.
Full slide with which one? I'm so used to the.
Down notes, coronavirus, then there is 4 dots and single screen.
Yeah, 1 minute.
That single screen.
Yes. 1 second. I'm just.
Please go to your right hand side.
1 second. My right hand side, yes. Yeah, I got it. This one?
Yeah.
Yeah, the other one.
No, adjacent to that.
This was 4.
Adjacent to the 4
I got
dots.
it. Yeah. Got it.
That's it.
Yes. So, dear friends, this shows how the life of an obstetrician is. We are experts in managing obstetrics, but when it comes to managing these technical hiccups, we are sometimes put into a corner. And when actually the pandemic hit us in the month of March, we really didn't know what we are going into. We didn't know what it is to have an issue like lockdown, and where we are actually told that we need to stop our OPDs and we need to change the way we are going to take care of the women. We always thought that we OB-GYNs are privileged and blessed ones because we are always bringing life into this world. You all agree with me that the other specialties always envy us obstetricians because they say you all are the happy lot who enjoy your way of life, because people are very happy when they come to you and they go back happy because they have a baby to take back. So that's what always obstetrics was about. Well, maybe people didn't know about the hard work, the struggle, the sacrifice, the quest for knowledge, and apprehensions. But in spite of everything, a small smile of the mother, the family, actually gives us enough energy to forget the struggle through the tears. But friends, what happened suddenly when we are hit with the pandemic? We were at a loss. We didn't know what to do because suddenly we were told, don't see elective OPD, tell your antenatal patients to consult you in the video conference, and then you take care of the patients. Gone were the days when we actually refused to treat the patient when they used to send us the WhatsApp messages. And now we are advising, yes, telemedicine is the way of life. So please call your doctor, WhatsApp the messages of your all the investigation, and we are going to treat. So friends, that's how we have seen this change of what a simple infection, a simple microbe has done to change the way we look at life. So let's see how this small microbe has changed the life of an obstetrician. So we have with us a galaxy of speakers. I've introduced all of them to you, and they are going to tell you what it is and how the obstetrician's life has changed. When you just quick look at the overview, when you look at the way Telangana is, we have about 1587 plus 46, it's somewhere around 1600. But look at the recovered cases, 1013 patients have recovered. Look at the deaths, we have a mortality of 40 patients. India, we have crossed the big landmark of 1 lakh cases, but we are very lucky because the number of cases whom we have lost are very less. And let's hope that we would be able to minimize the deaths further. When you look at the worldwide statistics, India has done well. The death rate in India is quite less. That's 0.2%. How is it that we have been able to do it? Probably because we are all very simple people. We have a simple prime minister. We have a simple chief minister in the Telangana state. And all of them took the necessary steps in time. They introduced surveillance at the point of entry. They evacuated the nationals who were stranded overseas. They did massive community surveillance through robust disease surveillance network. We have a huge population who's not educated, but the simple message given by our Prime Minister saying, stay home India, stay home, please don't come out, be careful and report if you have any problem, has made the patients believe in the strategies which we actually didn't know whether we are right. But probably when you look at the way things are going, we are right. And now, slowly we have realized that time has come that we open this lockdown bit by bit so that people start getting back to the normal, but at the same time, try to prevent the infection. Well, we have seen how the doctors and the police have actually joined hands to make it possible. Friends, now, after all this, let's see how we are going to face the day-to-day OPD and challenges when we are doing a practice. You all will agree with me, life is not going to be the same as it was before. Things have changed, but how is it that we are going to adapt ourselves to actually live up to this minute so that we can take care of our women and give the best possible obstetric care? Friends, whether it is the COVID pandemic, whether the infection, anything, but remember, we have our most important agenda, try to reduce the maternal morbidity and mortality and reach the SDG goal 2030. That is the reason why we need to gear up and start looking at how we are actually looking at our way we practice. So we have with us Dr. Vindhya. Vindhya, I think we start the panel discussion with you. Now time to restart the OP. So please do share with us how it is that obstetricians need to start their OP, what are the precautions as obstetricians, what are the OPD protocols, and most important, how to take care of the asymptomatic patients who walk into the OPD. People tell us, OT is not a dangerous place. The labor room may not be a dangerous place. You are prepared. But the OPD is one of the most important, maybe you can call it the time bomb. So I think all of us need to remember that we need to be well prepared to tackle this OPD, which is the most important place. So Vindhya, can we have your perspective?
Yeah, thank you, Shanta. I think we really enjoyed our lockdown. Some of us are not going for the regular OPDs and just managing the emergencies. But I think it's too much for us. We can't stay at home for this long, and it's not going to end now. We know that it is not going to end, and then we have to now go forward. So we don't know for how long we have to. So we have to get along and open our OPDs. So for a few months or 1 or 2 years, we don't know when it is. So first thing is we should know which sort of people to call to our OPDs and which people to be sent to the hospitals or refer them. So as far as possible, try to avoid certain patients like the symptomatic patients or the patients with confirmed cases anyway will go to the COVID hospitals, and the patients with severe respiratory problems also we should avoid, and people who are coming from the cantonment areas or the people like living with the contact person or diseased COVID diagnosed person should be avoided to our OPs. Then most of the time we should see patients only by appointment, and as far as possible try to avoid a walk-in patient. So take an appointment by telephone or online appointment, and the first step is like you have to protect yourself and the other patients also who come to our OPDs. So all this should be done by telephone or by online appointments, and then we have to triage patients at this level itself. And then you should ask the patient on the telephone or online about all the symptoms, what they have, fever or respiratory symptoms, and then if they have, ask them to go to a physician and then come back to us later. If any suspect, refer them as I told you always. And then avoid a routine follow-up and then avoid elective procedures. Routine follow-up for antenatal is not necessary according to the latest guidelines, and we'll come to that later. And you can actually guide a patient in your telephone calls or the WhatsApp messages for small issues. So like the guideline now is about minimum of 4 antenatal checkups for an antenatal patients at 12, 20, 28 and 36, and most of the time we should do a video conference or online, especially when they don't have any problem, and then a routine antenatal checkup. So what we can do is ask them to just check themselves, home monitoring wherever possible. The weight they can check, definitely they'll have a weighing scale, blood pressure if they have an apparatus at home, and fetal movement count. Explain to them how to look for the fetal movement count. For all these patients who don't have any other problem, we can ask them to do this. And according to the FIGO guideline, there are 3 ultrasounds at 11, 20 and 32 weeks for an uncomplicated case is enough with proper protection. So when we come to readying our clinics, now we have to open our clinics. So what should we do? Before opening, I think we should disinfect all the clinics, the room and the waiting area and the whole place we have to disinfect, get it scrubbed and do a spray, disinfectant spray. And we have to first call our staff and empower them about the new changes which are happening, what they should follow, the frequent sanitizing, the self and even the equipment in the room, OPD room or the desks, everything, and using of appropriate PPEs for them also. We, of course, we will use, but then even for them, we have to explain that they have to use, most of them, they use the mask, but it is down on their mouth, and they take out the mask and they talk. So we have to empower them, telling them they have to use it properly, because they should not infect even the patients. So doctors, usually they need a cap, a 3-ply in the OPD. a 3-ply mask or an N95 mask, a face shield, full cover gown, and latex gloves. This is the minimum which you need. And other stuff, of course, with all this, they need, if they cannot have a full cover gown, they can at least use some clothes which can be washed daily as soon as they go home. A full length clothes should be used. And the reception desks, a distance from the patient should be maintained for at least 1 meter. So as Shanta was telling, she went to meet some police officer and he had 3 rows of these pots, these ornamental plants, so that it will be more than 1 meter. So something like that the reception desk also has to do, and keep all the equipment ready. No touch thermometers, sanitizers, masks for patients, attenders. If they don't come with them, we have to supply or make them buy. So at the clinic, limit the number of patients, at least 4 to 6 patients per hour. You give an appointment like that, strictly you should tell them to come on time, and restrict the OPD timing to limited hours. In the beginning, at least let's start off with limited hours, and avoid walk-in patients. Avoid attenders as much as possible. And if they come, probably we can let them have a separate waiting room to sit. And if patient needs to be examined on a bed or a table, use a disposable, that paper towel on the table, and then remove it every time for each patient. And disinfected the OPD room every 2 hours. Stop the OP, get it nicely sprayed, disinfected, cleaned, everything. And every time a patient goes out, I think it should be the table and the chair where she sits should be cleaned with an antiseptic. And display at the clinic should be done in the hallways and the entrances and the strategic points like the waiting areas, elevators, and cafeterias. I don't know if we'll have, but anyway, we should have about the hygiene and about the respiratory hygiene, about the hand hygiene. All this should be had at these places. The posters, or you can have a TV screen going on. And at the entry of the clinic itself, we should, as far as possible, ask them to leave the footwear. And each patient should be asked to the symptoms of COVID, like temperature or the respiratory symptoms, and the temperature should be checked. And relatives also should sanitize their hands, and then give simple cloth masks if they come, okay, otherwise we have to provide. Waiting area also 1 meter apart, as you can see in the picture. Minimize clustering by giving appointments 4 to 6 per hour. I'm repeatedly telling this because some of them have a rush in their OPDs. And changes in the consulting room and OPDs, we always had our own style, but now I think we have to have different protocols for our OPDs. Modified the consulting rooms, and as far as possible, probably we should not have ACs, or we should have that UV based ACs. And educate on distancing, sanitizing, TV posters, it's already told. And the masks, N95 mask, and the glasses, face shields, gloves, cap, a must for us. For all of us, we have to use this. And cleaning machines such as ultrasound machines, colposcopes, fetoscope, all these should be cleaned as soon as you use it for one patient. And using disposable paper rolls for the couches, and change them after each patient. And please do not touch the documents of the patients as far as possible, and then ask them to send a photocopy of the previous reports, because usually these people come with a lot of files. So we don't know from where they come, so better not to touch them, and then use a new prescription and ask the questions, and then use a new prescription to give. And consultation fee, if you are preferably not to take by cash, use your online or credit card or Google Pay, anything. But in case there is cash transaction, you have a box, and then leave the cash in that for 3 days. And then sanitize the box after 3 days, at least on the top, and then take out the cash. I think Dr. Narendra Malhotra will tell us more about this. I don't have much experience on this because we do it by credit card. And for all medical professionals, as to summarize, we have to use only one pen and a phone and water bottle, preferably a disposable bottle, and decontaminate your phone regularly at frequent intervals. Do not touch anything. Everything is contaminated unless cleaned by you. personally or at your in front of your eyes. No watches, no rings, no bangles, and no dangling earrings. And hair tied and cover your head with a cap. This is at least we can avoid washing our hair every day. And shift to scrubs if possible, full sleeves, if available, or washable clothes, as I already explained. And wear double gloves. Keep your palms together when you're seeing a patient with folded hands, so that it's a habit for us to touch the patient. So at least we can avoid that by just holding both our hands. And don't use stethoscope. And it's sad to say, but then the times are changing. And wear goggles and masks. And wear footwears which cover foot fully, plastic or rubber, easily disinfected or washed at home. So clean your desk, doorknob and workstation yourself or in your presence. Keep doors open so that there's no... Today actually I saw somewhere where there's a foot opener. So you hold the door, that foot thing, and then open the door with the foot. I think that's better. We should start using that. And do not touch paper. Electronic entries is always better. Wash hands after every patient examination and clean your instruments with sterilium, especially stethoscope to avoid cross-infection, or the fetoscope, whatever we use. And avoid lifts as far as possible and close spaces. Don't touch lift buttons. If you have to, use your elbow. Get them cleaned frequently. Leave all your stethoscopes, fetoscope, everything in the hospital or in your clinic. Don't take them home. And decontaminated car handles also. When you go to the house, you should not take any of these things. So I think we should go ahead like this with all these changes.
Yeah.
And I think people at home will get a little agitated with us, but then we have to. And good luck to all of us.
Thank you, Vindhya. I think all of us obstetricians were actually used to wearing very good saris and jewelry, and we used to be very well dressed. Now all of us are in the uniform. Narendra Malhotra sir is giving me a smile. So I think, friends, that is now what has become to the life of an obstetrician. From being a very colorfully dressed obstetrician at work, now we are gone to a state where we are all in a military uniform, either in your scrubs or in your chudidar or somewhere. If I look at myself, I never used to wear anything but a sari. But the past 2 months, I've been wearing a chudidar to the OPD, and because I have to come back. And that is the way I think the life of an obstetrician has changed as far as the OPD and the hospital has actually turned out to be. Many of our colleagues have a lot of doubts, what to do, what do I do in my OPD, what do I do in my labor room, what PPE to wear, what to do, what not to do. So actually look at all this. I had a discussion with Dr. Narendra Malhotra sir. I said, he was in the forefront. He's running an obstetric unit. I think it's on for about 70 years or 80 years, I think, on 3 generations. And the work never stops. They used to have 300 plus deliveries to now, I think, about 150 to 200 deliveries per month. And all of them were going on COVID and non-COVID. And he was in the forefront taking care of the patients and the babies during the COVID era. That is why, sir, the whole of Telangana, and I'm sure many more people are watching, because they want to learn from you how best we are going to manage those of these issues which it comes to, like for example, when it comes to wearing the PPD or anything. So we want your experience about the COVID and how the labor room protocol set up in the non-COVID hospitals, the role of the triage. Do we need to have an isolation room? What are the precautions you advise our obstetricians and the others in the personal care? And the most important is the PPEs. Everybody has been talking PPE, PPE, PPE. The doctors, non-doctors, newsreaders, television actors, everyone on the road, everyone knows PPEs. But most of us doctors have no clarity.
Could you try again?
On the PPE. So friends, let's hear from Dr. Narendra Malhotra sir, how we are going to.
I don't know what you mean by I am the baby. So friends, let's hear from Dr. Narendra Malhotra sir. How about a web search for it?
I can hear some.
There are no slides here. We'll talk like this and I'll just show you some parts. So we've been into obstetrics since, as Shanta said, since 60 years, my grandfather's time to my children's time, 4 generations. And obstetrics never stops. The hospital, the new hospital, the old hospital had to be shut down because of the government laws of not letting less than 25 beds operate. So they just wanted to shut down. But the multi-speciality big 200-bedded hospital started working and working overtime because all the small hospitals all over Agra got shut down because of this COVID attack. So we started getting a lot of referral patients, unregistered, unbooked patients. We otherwise used to never practice unbooked unless they were very stable. But in the tertiary care, we used to. So now we need to understand what is triage. And what are 2 types of triage. So we just heard Vindhya telling us about the OPD triage. So you have one, the OPD triage, and you will have one, the inpatients or the admission triage. Now in the OPD triage, it's also very complicated because you have to, the patient cannot walk into your hospital as they used to. So they walk into a orange zone, a room, or your OPD hall, where their temperature is checked, hand sanitization is done, and a mask is given to them. So we have started giving them designer masks. So the women and the men feel happy. And we have started also drawing figures here. I've not got that here, but a lot of the designer masks, all colors and all are available. So this is given free to all the attendants and to the patient before they even come to me. Then they are giving that form, which is the self-declaration form, and then they have to fill the government form, and then of course they pay by PayPal, and if it is cash, it's a transparent box where they put the cash, they show the cash. That's the difficult part because now they might put the nakli money in it. So the false 500 rupee note, the old ones, people will do anything. So otherwise, if you're handling cash, wear gloves and sanitize, catch the note, sanitize, spray sanitizer over it, and then you can handle the note. And then still keep it in the box for 2 or 3 days, unless you want to spend that money that same day to buy vegetables or something. So that's how they have to. Otherwise, it's better they pay by plastic, the card, or transfer by the Indian Bheem or PayPal or Google Pay or anything. So the OPD triage, after all that, if they have fever, they straight away go to the fever clinic, which is a separate building in our block. And there they are checked by the physician. And if they found non-COVID, they come back to me for checkup. Otherwise, the other patients come for a checkup, and then we take the normal precautions of cleaning, swabbing. Here also, the laptop and everything has to be cleaned after every patient goes back. So that is the OPD triage. Now, inpatient triage is a little difficult because you need space. Smaller nursing homes usually have 1 labor room, 1 consultation room, 1 OT. So they will have a major problem because when the patient comes, you have to have an orange area. So they are admitted into the orange area, and the history, everything is taken there, a PV examination, everything is done there, and their COVID test is sent. Now, COVID test will take about 24 to 48 hours sometimes to come. In Agra, private COVID testing is not allowed now. So it has to go to the government, and the government van comes only once a day. After you register them today, they'll come tomorrow to pick up the test. So I'll get the report after 48 hours after tomorrow. So it's a major problem. So for me, that patient could be COVID, so I have to take full precaution. A full PPE is a must if she's going to deliver in 5 hours. Now, if she's going to deliver, she goes into a orange zone labor room, which has to be a separate one than your regular labor room. Or an OT and a labor room can be marked only for non-tested COVID patients. Here is where the personal protective equipment would be required. Now, see, there are many types of PPE kits. Many companies are making them, and they're coming packed, and they're coming sterilized, and they're coming unsterilized. Unsterilized kits can be sterilized. They can be autoclaved. There's no problem. Whether to use the one with a tape or not the tape. So 90 GSM with the flap, the zip flap not showing, the zip flap bigger, and the seams taped. Those are to be used in the OT. The rest of the places you can use any one of them. It is because here you will be directly exposed for more than 30 minutes to peritoneal fluid and to the patient coughing and sneezing on you. So it's a 30-minute exposure, which is the cutoff. So if the delivery is not happening in 30 minutes, please don't stand with the patient for 30 minutes. None of the staff should stand, and you have to change the staff. So like me and my assistant, both will not go into the delivery room, because both of us or all the staff, usually when all 10 of us used to come into the labor room and have some chat and fun. No, only 2 people. 2 people washed up for cesarean, only 1 nurse. So we have teams. So if this guest goes into quarantine, the second team can work. So we have 4 obstetricians now working in obstetrics, and we have two assistants who will be my team. So if I get infected, so the other team will take over. Or if my patient comes, then I have to be quarantined. So 30 minutes, your surgery is not finishing. Wash out, let the other team take over, even if you are fully protected. So that one guideline has come very recently. The PPE kits are many, 90 GSM, laminated with the tape, or you buy the one which comes from Netherlands, Lakeland, this the yellow one. This is the best PPE kit which is available in the world, and it looks very fancy, and it's an imported one, so it's not made in India, and you see the flap is more there, and there are no seams, so it's a seamless, so it does not need a tape, and the head cover of course is there. Below the head cover you should have a normal cap also, and you should have an N95. Now again, there are so many N95 masks available. So you have the N95 with a respirator. This you can use in the OPD. Now if you have COVID, then your breath is going out of this. This lets you breathe easy. But then this is to be used when people are 6 feet away from you. If the people are coming near, this one doesn't work. Then you need a M3 or a Venus company N95, and you see it's the lower thing goes here, and then the upper thing, and then you have to try to tightly press this. So definitely if this is worn for a long time, it is going to cause a little bit of suffocation. And if you're working continuously, then you have to keep on wearing it. Otherwise, if you have to remove it, just put it down to have a drink and then put it up. Once you have to remove it, it goes by the flaps like this. Don't touch the mask while removing. But these masks can be kept in sunlight, and the sanitizer is sprayed on it and can be reused after 24 hours for 7 to 10 days till they actually get spoiled. So nothing happens to them. That's the newer All India Institute. Similarly, the PPE kits can be standard.
Can I interrupt now? A lot of our colleagues have doubts about this N95 mask. So the AIMS have protocol told we can put them in 4 paper bags, ABCD, use them once in 4 days.
Yes.
We can leave it in the car itself.
Yes. If someone has sneezed on it, the virus droplets are lying here. They on paper and on these masks, it will survive for about 24 or to 36 hours, or maybe 48. So after 48 hours, the virus is going to die on driving. Or you want to be very sure, spray some sanitizer over it.
Okay, that's one more doubt. Then the other doubt some people have is, if they want to use the N95 for more time, can they use a surgical mask over the N95 or below the N95?
So a lot of people we see are putting a surgical mask first and then putting this, or a three ply surgical mask like that one. Yes. Now this is good enough for protection for droplet infection. If you're using a surgical mask, then you can use a normal cloth mask over it.
Okay.
So over the surgical mask to give you double protection.
Okay.
But N95, you don't need a surgical mask along with it.
Okay.
Then we have to prevent liquor and everything splashing on you. You have to wear a headgear. So we designed a couple of headgears. Like this one comes with a cap. And this plastic was not letting me see properly. So I cut myself and my specs are there, or I wear goggles. And I tie this off and I wear a N95 mask underneath, or even a normal surgical mask. I don't need an N95. It is. You get lots of these. You get ones which can clip on. You can get one which is simpler, cheaper, plastic, or you have the stud helmet visor, which is about 400 rupees. That's the best, because the vision in that visor is very, very clear, and it's very sturdy. It's unbreakable, and it can be sterilized, autoclaved, kept in Sidex, kept everything cleaner. Yeah, that's the one. Dr. Aruna is showing that. That's probably the best one which you have. So that is how we do them. Now, supposing you're not sure of your PPE kit, substandard or not. So then we have an alternate that we were using HIV kits, no, for hepatitis B. So you have this HIV kit. Now this HIV kit is sterilized. And the best thing about HIV kit is it has drapes. And it comes in a set for single, or it comes in a complete OT set. In one packet, there are 4 of them. So 4 people in your OT can use it. And some for 2,500, 4 can use it. So it becomes cheaper than the good PPE. And also it is more effective, because it is completely waterproof, completely viral proof, HIV proof. So definitely it is corona proof. And it has got extra hand and extra feet. And you can drape the patient. It's got drape sheets also. And this also costs about 900 rupees for one pair. And a good PPE also will cost you about 900 rupees to 1,000 rupees. Except the imported ones, which will cost you about 2,000 rupees. So now these were when you are with negative patients or only suspected asymptomatic. Now sometimes you fall into an emergency where you have to operate on or those who are working in COVID hospitals. Fortunately, I don't have to operate on symptomatic ones because we are not allowed, and we have to, as soon as it comes positive, we have to be sent. But in case you have to work with those, then of course you have to wear the respirator. Now this is a respirator mask, and it goes over your head, fixes like that, and your breath is going out. So this is a little heavy, and your voice comes lesser. But this is like a perfect protection against corona for you and for the others. So this complex device is used only when you are going on a symptomatic corona, or the anesthetist should be using it, and before intubation and all. So this is also available in a box like this. It's called V800, V7800, and when I look at the indications, now they've started writing COVID as an indication. So it has got lots of, it's used mainly for gas leaks and for chemical factories and for those who make vaccines in the vaccines. So it just prevents any virus coming out of you or in it. So this would be the most, or the tertiary level or the level 3 protection. So now the patient delivers in a holding area or a isolation labor room, and her report comes next day as positive. So that holding area has to be closed, sanitized for 48 hours. Otherwise, after every case, the OT is fogged, deep mopping by sodium chloride, hypochlorite, including the lights and everything, and the fogging is there. We don't put on the ACs. If the AC has to be put, an exhaust has to be there. So the AC air goes out. We don't want the AC air. And we use the cautery to the minimum, because cautery will vaporize and the virus can go. So that's why laparoscopy also, if you want to remove the gas, as we used to just pull off and the gas used to go into the OT, not like that. Attach a suction, so the gas goes into the suction, out in the suction machine and out of the OT, not released in the OT or not. So these precautions we can take, and see, if you take precautions, even if you're operating on and delivering COVID patients, if you take precautions, nothing is going to happen. Unless you're working with ICU full of symptomatic patients and intubating every second patient who's in acute SARS, then you are very likely to get, or you're talking to someone or don't take precaution. So that is what my views are, Shanta.
Sir, I have got one more doubt. What many of us ask is now these PPEs, some of them are coming sterile and some of them are coming not sterile. Now the main doubt of some of our consultants is we have the OT scrubs. So first we wear the OT scrub and then wear this PPE, and how in the like after washing.
First you wear the OT scrub, the OT pant and shirt.
Yes.
Then you wear the PPE and then you wear the sterile gown. So three layers.
So this is.
So you've got 3 layers of protection. And of course you must wear gumboots. No chappals, no OT chappals. Gumboots. Gumboots are a must for obstetrician, even in non-COVID patients. Anything, because you don't want your feet to be liquor and blood stained. Gumboots are a must.
Yes. So now you have clarified this doubt of PPE, and now very clearly you have put it. So those who are using the HIV kits are perfectly okay, and all our government hospitals are very lucky. They have got a huge store of HIV kits. So actually, the government was taking care of our healthcare workers in a perfect way, knowingly or unknowingly, because we were already stocked up with our HIV protection kits. So, and then the other doubt of our consultants is when the patient comes, do we need to wear an extra 2 masks or only the same routine? Do we need to change the masks? This is also some of the.
No, now how infection occurs. If you're sitting 6 feet away and you are wearing a mask and the patient is not wearing a mask and spreading droplets, you have about a 30% chance of getting the droplet infection, because they're going to come on a mask and finally you will touch your mask and you will touch everywhere or then spread. Now, if both of you are wearing a mask, and both of you are non-COVID and talking, you have only 1.5% chance of still getting an infection. So it's an infection if you're wearing a mask, and no need to change the mask. You change the mask after you finish your OPD.
Yes.
And someone is asking a question, I can see.
Yes.
Can these be sterilized? Yes, they can be sterilized. They can be autoclaved, or they can be ETO. If you have an ETO machine, put them in a plastic bag and ETO it. That's the best. And they are made of 90 GSM cloth material, which is waterproof, and it is laminated from inside. So on your surgical scrub, which I wear always, and then wearing a PPE, it is like 6 to 8 hours if you're in OPD, 6 hours of sitting in a sauna. Since last 1 week when I've started this double protection, I've lost 3 kg weight.
Very good.
Despite of eating all the parathas.
So that is a way of Jaideep.
So people who want to do weight loss, start wearing your scrubs and a laminated PPE. You see how you'll when you take it out, you'll be drenched. You'll be totally wet, and you'll lose 500 grams every day, I think.
And okay, let me ask you this question. Now we are actually looking at cost effectiveness. What are these reusable PPEs? Can we reuse these PPEs? Now this is one very big important question.
All PPEs till they get torn are reusable. The laminated ones. The unlaminated ones, which we give to the sweepers and the OPD staff and all, they can be washed every day. They can be put in a sterile solution and dried, or they can be autoclaved in a green packet. See, you autoclave, you put it in there and put it in the autoclave. Next day it comes back on your table as a sterilized kit. So you can sterilize them till they actually, and please remember the foot should be always there. With the PPE, your foot should also be covered. And over this, we wear the gum boots in the OT. But otherwise, the foot cover is very.
Okay. So how many times can this PPE be reused? Now, this is one more question. We
are reusing it about 7 to 8 times in the OPD area. In the OT, if blood comes, then only 1 time. If it gets blood stained outside, then no use. No, don't reuse. And if you handle the COVID patient, don't reuse. It has to be destroyed.
So what is this PPE kit made up of? What material it is?
It's some cloth material which is known as 90 GSM cloth. And inside, if you see, you look inside, there is a lamination.
Yeah.
It's laminated inside. So this is a double protection. Outside, it is a waterproof cloth-like material which is measured in GSMs. So 60 GSM for your general staff, 75 GSM for your nursing staff, and 90 GSM PPE for your OT staff. 180 GSM for those who work in virology labs and who are doing research and all that. So you get them. It's heavier the cloth, the more water resistant it is, waterproof.
Okay, so again, people have asked this question: how many times can we use the PPE?
See, if you're in your OPD 6 to 7 times, in your OT, if you get even a drop of blood, throw it away. Because you're wearing a gown over it and you get a lot of liquor and all, so the liquor will not leak into the PPE. But if blood leaks through your gown and it blood stain, it becomes blood stain, then please don't use it.
And people have got some doubts. How do we sterilize this respirator which you have shown?
This one?
Yes.
This one goes into your formalin chamber or you dip it in Sidex. Wash it with water. Only it has, see, this will come out. The sides come out. Sides are the filters. These filters have to be changed every 1 month. So if you're working in very polluted atmosphere, they get black. So they will be changed more frequent. Otherwise, you can just remove it and just dip it in Sidex or put it in your formalin chamber in the night and come back and use it next.
Okay. So I think these are some of the important questions which most of our colleagues are asking. So
respirator, as someone has asked, respirator is a pure permanent protection. Till it tears off or this thing. And it costs some I think 2,000 rupees, 1,920 or something like that.
Okay.
That's what the box says. But it's permanent. You can use it forever.
Very good. So many of us can actually, now the past 2 months, we have not been having many expenses. So I think all of us can invest in respirators, masks, and PPEs. Friends, so don't grudge your expense on these important things.
Don't buy sarees, buy all this.
There was no choice till yesterday. But yesterday, all the shops are opening and we have been getting SMSs telling us we are on. And
The
then
latest
all
collection is coming.
Yes. we are selling them in a very sterile atmosphere. So that is the SMSs which are luring us back to the shops. So, sir, thank you very much. We'll be asking you a few more questions. Now, let's go to the other important question. Now, we have with us Dr. Mahalakshmi. Dr. Mahalakshmi, we're very happy to have you and very proud of you and your team at Gandhi Hospital. And I'm very proud to say I am a Gandhi Medical College student. So, you have been taking care of the COVID patients. And can you just give us a brief about the maternity service in COVID and obstetric care, the neonatal care, breastfeeding, and what are the discharge guidelines in the COVID patients? So thank you for going to enlighten us on these aspects.
Thank you, Dr. Shantakumari. Very nice of you. Are you able to hear?
Yes, we can.
Oh, yes. So the first, this Gandhi Hospital has been made as into COVID, obstetric care. So now once that has been thought of, that Gandhi would be taken as COVID, then it has been divided into 2 parts actually. One is Gandhi originally is only for COVID and COVID suspects. And for non-COVID booked cases of Gandhi has been shifted to Sultan Bazar Maternity Hospital Complex as a separate unit of Gandhi. And then once having been shifted there, here we are taking only the suspects and this. Then I'll tell you right from the April 1st, we have statistics of, I'll show you the statistics later. And then the main problem what we are have been facing is, as you know that it is the only tertiary care level obstetric hospital which has been receiving referrals from all over the state and neighboring state for all the complicated cases. We were getting in the beginning all the cases also. And the main problem we faced in the beginning of this March, that is March ending or April 1st week, regarding blood and blood products. There was an acute shortage of the blood and blood products actually. And at that time, never we used to ask for the replacement or to buy, because in government hospitals, all of you must be knowing that we have JSSK scheme, which is a very good scheme that under which we can buy everything, whatever the obstetric patients are they require. So even with that, we couldn't get any blood and blood products from our own hospital or even from all the other blood banks which have MOU with the government, with Gandhi Hospital, and also even the private hospitals. As we all know that blood, okay, at least whole blood and hello.
we can hear you.
Yeah.
Please.
Yeah, right. Okay. So there was it. So blood, whole blood or packed cells at least 30 days and 35 days its life. But whereas it coming to the RDPs, that is platelets, which has only half-life of only 5 days. So we had a lot of problem with the platelets for the RDPs and SDPs. But somehow again recently we are getting, and even the patients in the beginning they used to have a lot of resistance when we used to tell them that we are not able to procure and all. But now once this COVID status has come, now everybody is very much aware of the problems and all, and they all are cooperating very well with us. That, and now we are able to get the RDPs and SDPs from any hospital, any blood bank, wherever we are trying to search from everywhere, and we are able to get it. And then about the attendance, I want the previous slide. The attendance, even though the woman is COVID positive, and if they are there, and the attendance, even though they are COVID positive, they are not coming as the attendance. And we ourselves, from our staff, we are providing the full-time attendance to these patients till the time of the discharge. Now coming to the statistics. Hello, are you able to hear?
Yes, we can.
Yeah. Now coming to the statistics, these statistics I am going to present about only the COVID, that is in the Gandhi original unit. Total cases are 72. That means COVID positive and suspects together. So we had only 2 cases of full-term LSCS done, and one was a multigravida with unstable lay, and the other one was a post-cesarean pregnancy, and both of them had cesarean section. And here the indication was only absolutely the obstetric indication, and one case had suction evacuation was done for missed abortion, and 18 cases are antenatal at various gestational ages, and then some of them are discharged because they were fitting into the discharges, and we had 4 gynec cases, and all the remaining 44 cases were the suspects or the negative cases.
Okay, can I ask you something at this junction, Dr. Mahalakshmi?
Yes.
Did you find
yes,
that in these COVID positive patients, did you find any increased morbidity, mortality, or any other problems more than the general routine patients?
No. Fortunately, we didn't come across any of these things. All of them are asymptomatic, but only one case, just she had liver enzymes raised, and now she is undergoing the investigations. Otherwise, none of them have any of these other symptoms.
Did they have more incidents of preeclampsia, or did you all have any intrauterine deaths in these patients?
No, so far only one abortion we have seen with this COVID positive patients.
Because what we have been observing and hearing from our colleagues in the private sector, a lot of patients are coming with preeclampsia and absolutely atypical symptoms, and some of them are landing up with intrauterine deaths, IUDs. But most of them are asymptomatic, and right now we are not in a position to test, so we are in a dilemma. So we're wondering whether COVID per se infection is causing all these atypical symptoms. So Dr. Narendra Malhotra sir, are you observing such things in Agra? Can you unmute and tell us?
No, we have, I think, a little bit of preterm birth incidence seems to be a little bit. I'm not sure it's because of this infection or not.
Okay.
But I think a little bit of preterms are occurring in the last 2 months, a little more. But no unexplained IUD, nothing, no about extra abortions. Of course, the incidence of MTBs has increased.
Okay. Thank you, Narendra sir. Yes, Dr. Mahalakshmi, please.
So in our experience, we couldn't see any of these untoward effects, maybe because most of them are asymptomatic, maybe. If they become symptomatic, maybe, as you said, the other problems may arise. And then coming to the labor room protocols, almost I feel, unless there are comorbidities or the obstetric indications are there for any other changes from the routine, there is no need for us to change the protocol. But the only thing is the monitoring will be a little bit more difficult because of that PPEs and all. And here the LSCS is reserved only for the obstetric indication. And the induction, if that like time demands or the situation demands, I think we can go ahead with the induction also.
No, Can I ask you what are the extra precautions you have taken with the PPE and all when you're having a positive or symptomatic, asymptomatic patients? Like we just heard Narendra Malhotra sir, is there anything extra that you have taken care to prevent infection for the healthcare workers?
No, the sir, what he has told is entirely 100% correct even for the positives. So, sir, what sir has told is almost taking into consideration as if everything is a positive case. The sir has told the same universal precautions we are doing, and we are taking and doing the things.
Yeah. At this junction, before we go on, we have with us Dr. Sarita Shamsundar from who is our Hyderabad person right now in Delhi. She's in Safdarjung Hospital. I think Safdarjung Hospital also you're having a lot of COVID patients, Sarita.
Yes, Shanta, there are 12 hospitals in Delhi which are COVID hospitals.
Welcome.
And one of them is Safdarjung Hospital. So we have one block which is totally dedicated for COVID. So, and which has, earlier we didn't have any obstetric patients in that block, but now we have a 12-bedded obstetric unit also over there, because we were having a lot of patients who turned out to be COVID positive, either they are suspect or they are positive. Yeah. But earlier, I mean, the LNJP hospital is entirely, the whole hospital has turned, they have made it into a COVID hospital.
Can I ask you one main thing is, like you have just heard Dr. Narendra Malhotra sharing his experience with the PPE, and we have heard Mahalakshmi is in the process of telling us. About the PPE is, what is it that you all are using and in your hospital, so that can you share with us so that Mahalakshmi is also there, we can see if we can learn from each other.
Yeah, so we have different PPEs for different different areas. So basically in the OPDs we are using, this is similar, is based on the ICMR guidelines. So in the OPDs we use, although the recommended mask is just a surgical mask, but we are all using N95 with a face shield and caps and gowns and gloves. So because any of these patients in the clinic OPD also may be positive. We have been running our OPDs regularly, even throughout this period. Although the numbers were limited, but we have been running OPDs.
Did you find any untoward incidents of preeclampsias, IUDs and all in the COVID positive asymptomatic and symptomatic patients?
No, I don't think. I mean, I don't have the statistics right now with me, but as such, we haven't found an increase in the incidence of pregnancy in these suspect patients. However, we see, since our hospital is a referral hospital, we get a lot of referrals from other states and other places. So, it's not a representative in that sense, but then it's not that it's increased in this time.
Yeah, thank you, Sarita. Going back to Dr. Mahalakshmi. Dr. Mahalakshmi, can you just enlighten us? Now, you are in a different ballgame. You know that the patients are already positive. So, actually, you are I feel, in a much safer zone than people who are in a dilemma. Whether it is positive or not positive. So, coming to the usage of the PPEs in this positive, what is it exactly you are using in the labor room and in the OT?
We are using these hazmat suits. Actually, when we are going into that positive patients, we are going one or two at a time, not many. Okay. So that if one person is wearing that suit, he will be there for 3 to 4 hours with the same suit. He will be observing the post-op cases and all. So once that person comes out, we will send the next person, so that we will not be wasting many of the suits at the same time. Otherwise, in the theater, as the sir said, we are minimizing and we are not using the cautery, like that we are doing.
Okay, so are you all using the only hazmat suits there and not the HIV kits, I suppose, because it's already a positive unit?
Yes, exactly. Over hazmat suits we are using the HIV kits.
Now, can I ask you about the N95s? Are you changing one every day, or how are you all using the N95s?
We are using, we are having that 5 1, 2, 3, 4, 5 numbered, and then by rotation, like that for 4 days we can use each one. That means if we have taken a set of 5, we are using it for 20 days while numbering.
Okay, that's nice. Yeah, please, let's go on to your neonatal care.
Yeah. 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 Here, usually, what is happening is there is no anywhere literature or experience to say that the baby is going to receive this that intrauterine or whatever it is. And so, but actually, what we are doing is we are delivering the baby and keeping in NICU, and then we are sending the swab immediately after birth within 24 hours, and then again 48 hours after that the second swab is being sent. So for both the cases we had, the two swabs had come negative, and here we are not giving the breastfeeding, even though there is no transmission through the breast milk. But the thing is how to collect the, and like social distance maintaining and this droplet transmission and all, it may be difficult to prevent that. So the pediatrician, in consultation with the pediatricians, we have started top feeds for them. And then till then, I think it becomes like that.
So thank you very much for sharing your experience, and please stay safe. Convey our very best wishes to the whole unit of Gandhi. We are very proud of you all and the good work you all are doing.
Thank you so much, Shanta. Nice.
Can you stop that share? Shall we go to the... Yes. So let's now move on to the other next questions. So now we have with us Dr. Krishna Kumari. Krishna, can you tell us how you're going to plan the inpatient obstetric setting, how the obstetrician needs to take care of themselves when they're doing their rounds, and of course not to forget the HDU. Now, yours is not a full-fledged COVID unit like Dr. Mahalakshmi's. Yours is a private medical college and a corporate hospital. So how is it that is where most of us fit into? So we need to know how we need to take care of ourselves, at the same time see that everything is going on. Yes, Krishna, can we have you? Dr. Krishna Kumari? Is Dr. Krishna Kumari there?
Yeah, sorry, I think I have been muted. I'm sorry.
Yeah. Yes.
Yeah, now I have unmuted myself. So actually, like you very rightly said, Shanta, this is, it's better to know that we are dealing with the COVID positive case rather than always living with a dilemma that every patient may be COVID positive, an asymptomatic carrier, or symptomatic but may not be COVID positive. So there's so much of confusion. Can I have my...
Yes. Can you share the slides session or Sana, are you going to share? Yeah.
Okay, I've got my slide. So when we are planning for an obstetric setting in the inpatient scenario, there are certain general principles which all of us need to follow. And most importantly, we need to realize that we have to admit the patients only if it's absolutely necessary. So there are many times where we may have to admit them for observation, for other purposes, which we should try to bring down in our present scenario. Then you have another important thing is for small things like circlage and all, you may have to go for a daycare surgeries rather than having a patient admission. And then it's very important that you limit the movement of the patients, and you have to minimize their personal belongings. Other important thing which we have to take care is the room ventilation. There is a lot of problem. Again, the rooms are of different types. Now it can be a private, completely corporate setup, or it can be general ward patients, or it can be smaller hospitals where there will be sharing rooms. Different settings are there. If it is an independent room, it's okay. But if it is in a general ward or a sharing room, preferably it should be an independent room, especially if it is suspect. Otherwise, you have to have a proper ventilation, and you need to have an exhaust fan, which is very, very important. If the AC is being used, there is a minimum of 6 to 12 air changes per hour should be done, and the filtering of exhaust air should be done. And the beds should be of at least a 3 feet distance from one bed to the other bed. It's always better not to share the equipment, and after every patient, when you see the use any of the materials, then you have to see that it is cleaned up, especially like fetal monitors or whatever you are using. Then, of course, housekeeping. It is very, very important that you have a very good housekeeping, and they should have a checklist. Like already it has been discussed, cleaning up of the wards, the surface, everything is very much important. And they should have a checklist and the timing of when they have cleaned it. At least 2 to 3 times a day is the minimum cleaning that they have to do. The visitors register should be there and their data should be entered and they should be checked and they should be wearing a mask if at all they are permitted. So this register will help you to trace the patients and the contacts in future if needed. Another important area when we are going into the wards are the lifts, the wheelchairs and the stretchers. So there are principles for each and everything. I think it will be a long time if we talk about each and every aspect of it. So how to take care of the lifts and how to minimize and how each one should face away from each other. And the minimum number, the permitted numbers should be followed strictly depending on the size of the lift. And wheelchairs and stretchers also should be very much cleaned up after every patient is transferred. Then your dustbins should be touch-free, and the biomedical waste management. You should have a perfect biomedical waste management protocol set up and how to dispose, including your PPE, the simple things like masks. How do you dispose them? The system has to be very robust. So I think there are a lot of importance should go for housekeeping and training of the staff. And of course, the staff training starts from the housekeeping level to the ward boys, to the technicians, to the the phlebotomists, to the JRs, to the interns in the medical colleges, everybody. And of course, the consultants. So you should have all these in place where these are the general principles for any of the wards which all of us should follow. So next, so now we have a scenario where the patient is asymptomatic. Then that is one scenario. The other one, patient is symptomatic with something like ILI, that is influenza-like symptoms, that is she has fever of more than 38 and respiratory symptoms. Now you need to put this patient in the hospital if it is a necessity. Then before you get the COVID test, like already said, that different types. Yesterday only we had the ICMR saying that now you can do the TrueNat. TrueNat comes within a day, whereas previously our RT-PCR is to take more than 24 hours to get the report. In Hyderabad, we used to get it in 24 hours, but TrueNat will give you a faster report. So whatever test you are choosing, before that, it is very important that we remember that obstetrics anything in obstetrics cannot be postponed just because you do not have the report with you. That is the first dictum. So you have to continue working even before the report comes, as per the situation and as per the patient. So if in such a case, if ILI is positive, the symptoms are suggestive of ILI, then you have to need patient to be admitted. You have to preferably put her in an isolated room with preferably with a negative pressure, and everybody should be with a proper PPE. That is whether it's a visitors or the healthcare personnel, everybody entering the room will be fully dressed. Then delivery and neonatal equipment, as already Mahalakshmi has already said, Dr. Mahalakshmi has said, as if your patient is COVID positive, you manage the patient from here. I think Dr. Narendra Malhotra and Dr. Mahalakshmi have given us a very good perspective on the PPE and how to go about this with these cases. Now, if your report comes positive, then you have to, of course, as per the government protocol, you refer the patient to the wherever it is recommended and in your location. Then you have a test which is negative, but remember, a test which is negative, it need not always be negative. If this patient, there can be a false negative too. So you do not give up on your care. So continue. If there are symptoms, continue to take all the protective aspects as if the patient may be positive. If the patient doesn't need immediate any delivery or any procedure, you can send her for a self-isolation at home, and then with the clinical self-monitoring. And if the symptoms are still there, you have to retest her. That is how we go about with this patient. Then in the wards, you have another group of patients where they are postnatal. Postnatal patients, the regular protocols are followed. You monitor for any symptoms of each patient. Like we routinely take the history for any postnatal ward, we go for rounds. We have certain things which we look for. In addition to that, we are also looking for the additional symptoms which are suggestive of any, at least ILI or respiratory symptoms are cropping up. Then lactation, already she has said, if you are planning on rooming in or co-location, it is very important that you have to take the consent of the patient. Even though she is not positive, you have to, any patient who wants to have the baby with her, then you have to take a consent. And of course, advise her on hand respiratory hygiene as well as surface disinfection. These are the important issues which she has to take care of if she is keeping the baby with her. The diet, we all know that we have to give a boost up of protein or whatever immunologically stronger diet. Discharge summary should carry the notes of the relevant COVID symptoms which she may have to look for in future. Even if she is
slide
so that is about the patient. Then coming to the self-care of the obstetrician, which is who is doing the ward rounds. So when you're looking at yourself, what is it that you need to wear is your protective gear. So you have to have contact and airborne measures should be taken, which include an FFP2 or an N95 mask. That is mandatory when you go for rounds. You have to have your gloves. You can have your gown and of course eye protection. These are all a must when you go for ward rounds. And you also need to have your work uniform in place. You cannot, it's always preferable whether it's your scrubs or whatever you want, or to wear a gown over your clothes and then go. It's better to have a work uniform. Then the next most important thing is, it's like those days have gone where we used to go, especially Dr. Mahalakshmi must be seeing that grand rounds from the HOD to the younger-most people will go all together to do ward rounds. Now I think we have to limit our bedside time. We spend very little time with the patient, as little as possible, and try to minimize. Even if you have to see the reports, like for example, you want to look at some X-ray or a CT which has come up and you want to see, preferably look at all of them in your room. Don't go and stand in front of the patient and take out each report and start looking at them. So do your homework away from the patient's bedside, and then go and just spend as little time as possible with the patient. Then coming to the dressing, I think the daily dressings should be minimized. So we had a protocol of daily dressing, whatever it is. If we have a protocol, then you have to minimize these daily dressings. And you have to remember that the dressings can have some aerosol generating procedure. It can be an aerosol generating procedure. So it's always wise to wear a face visor when you are changing the dressing. Of course, behind all this, hand sanitation is a background which is always there, mandatory. And of course, you have to always know whether whatever procedure, if you're taking up even minor procedures, you have to know whether it is an aerosol generating or not an aerosol generating procedure. And accordingly, be wise and decide on what extra. What we have to remember is that it is always better to err on being overprotective than being less protective, because we are confused. So if I don't know that whether I should use this or not, better I take extra precaution and be more careful than being less careful. And another important thing is science. We only said science is, we always say science is dynamic, not static, but COVID is super dynamic. It is changing so fast that it is very difficult for us to say this protocol is the best. What we are advising is for today, that what we can do the best as and of this minute, I can say. So basically, the next question I had was on HTU, the last question. So it's very important again that you know whether it is non-COVID or COVID. Of course, COVID goes to your a separate ward, so we are not bothered. So these are the patients who have been tested negative. They can be asymptomatic. Then you also have to be protective. But if they are positive, and they're shifted, fine. In between are those where they have these influenza-like illnesses or the severe respiratory syndrome, including pneumonia, which is non-COVID. That means your COVID test has come positive. So these are the patients which are kept in HTU. But then you have to differentiate these patients from those patients which genuinely, for other reasons, we keep in HTU. Like, for example, severe preeclampsia. Some such conditions where they're kept in HTU for other reasons other than anything related to COVID. So there are two groups of patients in the HTU. So what I believe is, rather than donning and doffing is one thing which everybody has to perfect for your own sake, for self-protection. Donning, at least you're wearing something which is clean, but doffing, that is the time when every healthcare personnel is likely to get infected. So being perfect in the art of doffing and not infecting yourself is the most important thing.
Yes.
And then as far as the patient is concerned, we have to keep on watching if she's developing any signs of difficult breathing, any breathlessness, any cough, or any response, lack of response to your questionnaire, whatever it is. This is continuous monitoring has to be done.
Yeah.
And hourly observations for respiratory rate, monitoring both the absolute values as well as the changing trends have to be taken care of.
So Krishna,
always oxygen titrations. The most important thing is to keep oxygen titration beyond 94%. Chest X-ray and CT in the antenatal period also has to be taken with a proper shielding of the abdomen. It is not an excuse not to do a CT if required. IV fluid management is another important thing. Patient needs hydration, but if you overload her suddenly, she may go into fluid overload. So just give 250 to 500 ml, reassess, and then again look for, if needed, give a fluid resuscitation.
Yeah, thank you, Krishna. I think
these patients by your SOFA score. We always have this SOFA score, and if the patient is getting worse, take the help of everybody. Shift the patient to a multidisciplinary approach, whether it's ICU or a COVID ICU.
Thank you very much. Actually, after hearing your this thing, I got scared and I put on a headgear. This is to show you all. This is the one which Narendra Malhotra sir was telling, which is very good. Like this thing, you can open it and use it, and this is very sturdy. You can wash it soap and water, and it'll keep you safe. So thank you very much, Krishna. Now let's go on to the. Can you stop the share? We will go to the next question. Now we have.
One thing about the mask for the patients, the patients should not be wearing N95 mask, especially the ones with the valve. So if they are wearing the one with the valves, they should immediately be changed, because that's more harmful to us.
Okay. Right. Thank you.
Actually, in the labor room, you also need to have a screen between you and the patient, so that it's ideal to put a screen. The patient may remove her mask anytime, and it may be an aerosol generating screen that is coming out of her. So always have the screen like you're doing a major surgery.
That's why I removed the shield, because the patient has gone out. And the patient has gone to Narasimha Reddy, sir. Sir, can you tell me briefly, sir is working in a peripheral center. So there are a lot of our friends in the districts of Telangana who are keen to know how the tips and tricks with less cost-effective methods of managing patients. Sir, can you tell me in short, brief about how you manage at the
Good afternoon, everybody. Esteemed Dr. Malhotra ji and Dr. Murli Krishna and my dear colleagues from Hyderabad, learned colleagues from Hyderabad. If it is scaring you people who are sitting in major cities, how it is going to be people who are practicing in rural setups or semi-urban setups? One thing for sure, the incidence of COVID positivity is very, very minimal. That has to go into our minds, because we have to boost our confidence to take up the cases. If you are worried, you can't do anything. The possibilities, can have the slides. the possible precautions wherever possible, wherever feasible, has to be the maximum, because you can't fulfill all the criteria which have been described by my learned colleagues. Probably for them also it may not be possible in the best of the best setups, even in Hyderabad, or for that matter, even in Agra and so and so. So in a rural setup, it's very, very difficult. As far as the few things I would like to touch upon, lack of available PPEs. The best alternative, as sir has told, it is you can make use of the HIV kits and so on. As far as the re-sterilizing of these kits, it is, you can do it. You can do up to a number of times. Maybe it will last for another 10 or so times. And that it can be up to 30 GSM. 30 GSM means 30 grams per square meter of area. This is in a non-woven fabric. It is in a polypropylene. The coating inside has got some absorbent material. Sir has mentioned about the absorbent. But whereas what we are getting, we don't have that. But nevertheless, wherever possible, if you have the best PPE, make use of it. If it is not available, whatever the available, you take care. You have it, use it, because something is better than nothing. And with that way, you can manage your own way. And as far as the management of the OPD is concerned, I am suggesting, and what we are doing is, we are wearing the cover-all. I don't name it as an PPE, it's a cover-all. You have to cover all of your body parts. That's I'm making the people to understand better. You know, even when the patient comes to my clinic also, cover all of your body parts, including whatever you want. So that I will tell my patients, I tell my staff also, you cover fully whichever the way possible, you wear it. And wearing the mask is concerned, we are using 3-ply masks, and wherever the availability of the N95 mask is there, it's very good. But the problem here is when you use N95 mask for over a period of 3 to 4 hours at a stretch in the OPD, you will get headache. So in the OPD already, what are the precautions all have to be taken? Only my colleagues who are practicing outside cities and all, just make a partition. Make a partition between you and the patient. This is a plastic partition. So coming to the PPEs, disposable non-woven gowns can be sterilized with UV rays, and autoclaving is also possible. UV rays is very, very simple. Most of the theaters have got the facility of UV rays. You can hang them after the usage, you can hang them overnight, or at least 20 to 30 minutes is more than enough. If you do it overnight, is also good. Cloth masks are preferred in rural areas because they can be reused autoclaved. And I am advising my staff members, use at least 3 or 4, keep it in your pocket, use them, and you keep the used one in a plastic cover so that you can autoclave overnight. Can be provided to all the staff members, including the housing staff. Because what ICMR says that, you know, doctor can wear this for the housekeeping person can wear this. But it's not true, because it won't work out, because the staff can complain you that, you know, you have taken care of yourself. You have neglected us, because that should not come into us, because they are also in touch with the patient as we do. So please provide all the facilities what you are doing. And the most important ones which I am emphasizing on my staff members and me is the face shield, and including the mask and gloves. To all the members, whoever they are there, all the members have to wear it. Next, please. Then triaging the patient, of course, telling is easy, but very difficult. Only way you can triage your patients is whenever the pregnant lady comes who is in near term, should be given a preference and should be sent as quickly as possible. And the number of the patient's examination is doesn't matter much, because as much as time you spend with them, there is every possibility that you may have it. So limit yourselves to few minutes, and most of the times what I advise is to have your ultrasound machine in your OPD itself, so that you can dispose of your patient, pregnant lady, as quickly as possible. Because I do it is, the moment the patient comes into my clinic, my chamber, she is lies down, I will ask my staff to spray simple ethyl alcohol or the spirit, surgical spirit on the abdomen. I do scan so that, just for a few minutes, you will know the well-being of the fetus. Instead of using the fetoscope, of course, I have stopped using the fetoscope right now. I am not putting anything. I am not palpating anything. Probably, maybe it's against the PCPNDT, because I may not be taking consent every time I put it on the abdomen of the pregnant woman. But it's a thing which we can circumvent. Sterilizing the abdomen with surgical spirit before
sir,
the
I think we need to follow the rules of PCPNDT, COVID or non-COVID. So let's start.
The good news is PCPNDT is suspended for 6 months.
Okay, so that's a good news from you, sir. Thank you very much. I am not doing any wrong thing. I'm literally worried that I may be doing the wrong thing.
Narsimha avatar of Narsimha Reddy, sir.
Sir, another best thing which we are doing is we are putting an exhaust should be at the end of the patient. Suppose our exhaust is in the opposite direction. I changed my table so that the patient head end should be on the exhaust. Suppose in a case where you don't have the exhaust in your room, we are asking in a suction tube, suction machine, and that has been attached to a saffron solution or any antiseptic solution. You can connect it to it. That will suck into the antiseptic solution, and the air which is coming out of the suction tube may be a sterile one. Maybe a sterile. That way you may be making the room little bit sterile. As far as the management of the emergency cases, I haven't stopped doing my surgery since March. I am doing it because no way we can avoid these things, because we have to live with these things. And I am doing for the last 2 months, probably delivered more than 100 patients. So getting all the team on time is very, very difficult in this hour. Lack of experience in OT, in handling infectious diseases, this is a concern for us. Doing all the cases, taking all universal precautions, just like HIV and HPHS is followed, because we are used to it. That has been told to my staff. Consider this patient as an HIV patient. You have to take care of yourself, because I cannot explain every bit of it, what to do, what not to do. All the more, all the time, the suction is on. If the central suction is available, it is very good. Otherwise, using hypochlorite suction or the suction attached to the hypochlorite solution is the best. Suppose you have the central suction is available, that may be the best. Before you bring the patient into the theater, the suction should be on for at least 4 to 5 minutes. Wherever possible, disposable kits are used. Otherwise, gowns, drapes are dipped into sodium hypochlorite solution immediately after the surgery. Because many a times, probably if you are using HIV, HPHS, it can be disposed of anyway. But suppose if you are using only linen, what to do? Should we discard all the linen? No, it's not really required, because immediately after donning, you can put it into 1% dilute, 1% sodium hypochlorite solution immediately after donning. That will do the job. All the mops are discarded. This is the one has to remember. For all OBG cases which can be done under spinal anesthesia are managed with clinical history only. Of course, few tests are being done whichever they are available, and so on and so forth. But if they are available, you can do it. Otherwise, if you are contemplating any surgery under spinal anesthesia, clinical history is more than enough. If general anesthesia is contemplated or required, the chest X-ray is advised, because I am doing it. There is no harm in doing chest X-ray at that time. For all the gynec emergencies, wherever possible, CT chest is advised. Otherwise, X-ray chest is used. Because in the past 2 months, I have done 10 cases of lab ectopic pregnancies, pregnancy, operated laparoscopically, because that is the area where we are finding very difficult to handle, because it has been told that peritoneal cavity has got tenfold increase of viruses rather than in the lungs. So we are connecting the exhaust. Whenever we are sucking it, it is to be directed through a hypochlorite solution. If the exhaust air is let out into the theater, suppose you are not using the central section. Suppose if you are using central section also, if it is diverted to the hypochlorite solution, it's well and good. If it is not so, okay, it goes out and it goes into the air outside your hospital. But better is always should be sucked through the hypochlorite solution.
Thank you, sir, for the.
Yeah.
I think you got one more minute.
Okay. To get lab test pertaining to COVID is very, very difficult. So, more so in emergency cases, no private COVID labs are available in testing in semi-urban areas, and all the suspected have to refer to COVID hospital. It is the most difficult job. All said and done, once you say that, you have these, you have the temperature, you have the cough and all. So probably you may have the COVID suspect. I am suspecting you as a COVID. So I am referring you. The patient's attendance will be on to you. It's very, very difficult. In such of the situations, better to handle these patients rather than referring these patients. Unless the patient has got the severe symptoms, 100% you have the evidence that, there is a CT or the chest X-ray is hazy and all. Not just the temperature, not that she has got an occasional cough. Probably may not be possible for us to refer these patients to a COVID hospital. Once they go there, they will say that, you don't have any of these things. Why they have turned you here? Unnecessarily they have referred you. So because it's a big problem for a small nursing home or who is handling few patients day in and day out. So implementation of standard operating protocols here is very difficult with limited understanding. Not that, we should not lose our heart. We should not lose, because we have heard our experts speaking to us, many things that they have told. You may not be able to implement everything as they have said. But my request is, don't lose heart. Try to implement as many things as possible. Stay safe and enjoy your profession. Because for a gynecologist, just a love of the mother after giving birth with her is the most rewarding thing to you. Because that we would like to have on our faces too. Thank you very much.
Thank you, sir, for those lovely words and showing the path that all is not bad. So now let's move on. Next we go on to our dear friend Aruna. Aruna, can I request you to tell us, Aruna is going to tell us how they're going to manage at the tertiary care center, that's a big Janana hospital, the OP, labor room and OT. Aruna, we have to have Murli Krishna, our guest speaker, so you have to come quickly and tell your points, and then we go on to Murli Krishna. Yes, Aruna, we are waiting for you. Yes, Aruna, can you start?
Yes, ma'am, starting.
Yeah, quick, because we are running out of time. I want you to finish fast.
I'll take in a few minutes.
Yes, quick.
Thank you for the opportunity, ma'am.
You are going to be a gynecologist, quick in and quick out.
Yes, definitely. Under Usmania Medical College, we have 3 hospitals, which are obstetric hospitals. One is Modern Government Maternity Hospital, Petla Burs, Government Maternity Hospital, Koti, and one more hospital is Nilofer. And these are the main referral centers. We have lot of referrals, not only from Telangana and beyond Telangana also. And we had all kind of high-risk obstetric cases during this lockdown time. Many challenging cases we have seen. As you have asked, ma'am, we had unexplained IUD we had ruptures, too many ruptures. One day we had even ruptures and PPH cases and abruptio placenta and all those cases. And all doctors in working.
I think the audio is little like, can you hear Aruna? No, there is some problem with the, audio. Aruna, can you hear me?
Yes, I can hear you.
Yeah. Please continue fast. The outpatient.
Yes, this is our outpatient, ma'am. There is definitely a good social distance. And obstetrician is wearing a OP gown. This is a kind of room where we fulfill the emotional and healthcare needs of the patient. Here also we follow all the social distancing and masks. This is our triage. A well-trained team is available here 24 hours, accepting all the cases of shock, respiratory failures, critically ill mothers, everything, and they send the woman wherever it is necessary. There is a testing facility in our hospital where our microbiology department has developed, and we take the test and sample and send it to Usmania General Hospital. And this is our labor room, well-equipped labor room. Almost our statistics have doubled now. We are 24 hours ready to accept any kind of deliveries, and it is almost 45 to 90 deliveries in 24 hours. I thank our superintendent Nagamani madam for giving us all the facilities and the PPE kits, the shields, everything, and we are ready and working. And this is our operation theater, and we have too many challenges here, and there is a separate OT for the suspicious cases. And we have a very good blood bank officer who is doing a good job in providing the blood even during this COVID time also. And one word about our anesthesia team. They are very efficient and skillful in managing OTs, all critically ill patients in MICU, OICU, and admission room emergencies also. And we also have an isolation ward where we keep our suspicious cases and the women with mild symptoms, and where we are waiting for the result. It's a labor room for these suspicious cases. And MICU, OICU, which is well managed by our anesthetists, even though we don't have an intensivist post, our anesthetist will do a good job. It's well equipped, saved many lives, and positive cases sent to COVID hospital, and this is Gandhi Hospital. We could save many mothers' lives who were critically ill during this COVID time, thanks to Telangana government, thanks to DME sir, Dr. Ramesh Reddy Garu, and thanks to our superintendents and team of doctors. Thank you, ma'am.
Aruna, you have seen the government hospital in Telangana, which is as good at par with a private hospital. That's Naren sir. Don't you agree with me?
And we have all kind of facilities, PPE kits in the OPD, wards, OTs, everywhere.
Perfect. So we are doing our job. So let's move on. Friends, can you stop the share?
Sure, ma'am.
So you have seen how well we are able to manage the cases. Now, friends, we have with us our most interesting guest. We have with us Dr. Murali Krishna. I have already introduced Dr. Murali Krishna. I hope you are there, and I'm really sorry to keep you waiting. Murali Krishna is the anesthetist in UK who has been working in the NHS. He has actually moved from Hyderabad to, and very proud to say, he's also from Gandhi Medical College. So we are from the same college. From there, he moved to Africa, where he served the African women, and then he has reached UK. Now, Murali, you as an anesthetist and being an anesthetist with the obstetricians, can you just give us an insight of how to manage the OT in emergency situation, managing the critically ill patients?
Yeah, I would definitely. Yeah, I've given my slides to.
Yes, can you just share them? Share the slides, friends. Let me tell you. I think Krishna has given me the okay to share with you, friends. God forbid if one of us tests positive. We are always scared, what is going to happen if I become positive? How can I prevent myself from getting the infection? Now, I have the hero in front of us, Dr. Murali Krishna, who has actually got the infection when he was taking care of the patients, and he has come out, and we are so happy that he is again healthy. And that itself shows that doctors are there to take care of the patients. And this is a good lesson to all of us doctors, not to be scared. And we are going to hear from Murli how to take care of the patient and how to take care of ourselves. Yes, Murli, the screen is all yours.
Thank you everyone for having me. So managing the OT patients in an emergency situation. For this, we had to prepare before the COVID. When we just heard about COVID, we just started preparing from that time onwards. So there is a pre-preparation stage where we did this. When the COVID patients started coming, we actually stopped elective surgery, and we identified one of the theaters as a COVID positive, apart from the normal theater that we had. So preparation of this theater was very, very important. So identifying structural identification is very, very important. Which theater, where we are going to do these cases, that's very, very important. And keep the area very, very clean. Even the surroundings should be all the equipment in the corridor should be removed from that area. Then coming to the donning and doffing, you need to identify the donning area and doffing area. Donning area is not all that important, as somebody said, because donning is we are wearing all the sterile gowns and everything. But doffing is very, very important. There are a few videos on the YouTube, and we also have made our own video to teach everyone how to doff the equipment. It is very, very vital, and in the process there's a possibility that we can infect ourselves. So doffing should be very, very precise. So as I said, there should be a clean corridors, and then preparation of the obstetric equipment, like, whatever, because it's going to be a new theater for us. In your setup, maybe you have many theaters, I don't know. But for us, we had to create a new COVID theater. So we had to keep all the obstetric equipment available. But still, there's a possibility that during the procedure, there is a possibility that you might need some more equipment from other places. So what we did was we had extra personnel, one in the theater, one outside the area. So the inside person will inform the person outside, and that person will go. She will also be fully donned. She will also go and get the equipment. Coming to the preparation of the anesthetic equipment, this is very, very important as well. We have prepared all these. We have made another trolleys of epidural trolleys, spinal trolleys. We have made emergency drugs separately. We have prepared the postpartum hemorrhage drugs separately. We have kept intralipids in a fridge separately, and things like that. Just keep everything, be prepared for that. We have prepared another difficult intubation trolley separately. We have prepared another resus trolley separately. And this is all pre-preparation. So, and then apart from this, training of the staff is very, very important. So run the simulation drills. It is very vital to run the simulation drills. And once we get one case, we were having a few, small get together, and then talk over that. How did we do, and what are the things lacking, and what are the things that we can learn from this case. Now, during the procedure, we have you need to know, in the theater we have the anesthetic room and the theater proper in our setup. So we were not using anesthetic room. We took the patient straight into the theater proper and do the anesthesia in the theater. Before patient came to that, we need to identify which is the, you need to keep that all as a dirty area or infected area. Imagine that as an infected area. Before entering, you don, you go there, and then go straight, take the patient straight into the theater. Patient comes with the mask. Partner comes with the mask as well. Then there will be a runner who is donned and ready outside for you. Anesthetic procedure, if it is a regional anesthesia, we do the regional anesthesia with a fully donned with PPE AF3 masks. And also for the, if it is a GA, again we do fully with full protection, including the surgeons, everybody full protection. Then there's a, as I said, there's a person to communicate inside as well, extra personnel who communicates the runner. Recovery, we recover all these patients in the theater as much as possible, unless until another. We don't have number of cases like you all, like 45 to 90 deliveries. We have got less number. So we have some time to recover our patients in the theater itself. But if you don't have that facility, then take them to a designated recovery area. You need to have a designated doffing area where we kept different disposable boxes, and also we put laminated sheets how to do each thing. So we take out everything separately, and then including the shoes will be cleaned, and then you wash out completely, and then you come out of the doffing area, and you never go back to that area. That is in the theaters. We use that as an anesthetic room for the doffing area. And then appropriate disposal of the equipment is very, very vital, because this is a high source. This is the major sources of infection to spread. Yeah, that's about how we manage the patients in OT. Are you with us?
Yes, thank you, Murli, for the lovely information. Before we go on, can Naren sir, can I take up the question with him how to cope up in case of infection? Can I continue with Murli, or you have some more time with us?
No, whatever you want.
Okay, so Murli, can you just tell me how you have coped up with the infection, and God forbid if somebody does get an infection, how is it that we need to cope up? Can you just tell me? That will be like an immunity booster for all the
I found
obstetricians.
this on the web.
Yeah, so if you have observed me, I was actually stretching myself and I was not able to sit properly for some time. This is the first time I'm sitting like this for about a couple of hours, and I'm still having body aches and spine problem as well. This is what I've observed first time now. I'm sweating as well. So this is how it is nearly a month since I've tested positive. So as I was working in intensive care and as an obstetric anesthetist for the January and dealing with all the COVID patients from February onwards, it started to us. February, March, and April, I was working well and then coped well. We had, as I said, we had proper planning and we had proper preparation. We had proper simulation trials as well. So we did very well from that point of view. On 24th of April, that evening I finished my late shift, and then I felt not very unwell. I was feeling body aches, and I was feeling feverish as well. So I went and checked my temperature, and it was normal. So I came home. I told my wife that I'm not feeling really well. I ate and slept. During that night, I was having lots of body aches and headache. The next day morning, I just called the COVID line and then I told him about my symptoms, which are very mild at that stage. I was even reluctant to go and actually talk to them. But then they said, come and give the swab.
Yes.
So I went and gave the swab, and it was positive the very next day. The very next day also, I was having mild body aches. That's all. I thought, this is nothing. I thought COVID is nothing, frankly speaking, if it is the case. Then that night it started, temperatures went up to 38.5, 39.5, up to 39, 45, 40, and body aches started. The whole of my body was like burning. There were pins and needles all over. Even the sheet, light thin sheet, your clothes were all burning. And it was like that for about 13 to 14 days. It never stopped. In the meantime, I also had GI symptoms, diarrhea, dysentery. I was dehydrated, pathetic, was isolated, all alone at home, curling in the bed into half, and just sometimes you just cry as well. You don't know what is going to come to you, because I've been treating these patients. I've seen patients 36-year-old dying, 42-year-old dying, 50-year-old dying, 60-year-old dying in front of me. So I was actually not knowing what to do. So at about 7th day or the 8th day, I went and gave my bloods, and also chest X-ray was done. At that time, my chest X-ray showed mild changes in the left base. I just gave the bloods and came back on that day. Symptoms got worse and worse and worse. And on the 14th day, I think district nurse came and collected bloods again. Those were all very abnormal. Looking at the results, my GP suggested that I should be admitted to the hospital. I was a bit reluctant at that stage, because I know that this is 14th day. This is the time where there is a cytokine surge, and potentially I might get secondary infections, and the hospital is not the better place to be during that time. So I was reluctant to go to the hospital. So what I said is, I'll wait for one day and then I'll go. During that night, my wife, she started counting my respiratory rate. It was about 32 or so. So I said, no, it is only 20. But she made me, our GP, FaceTime to count my respiratory rate. So being an anesthetist, what I did is I increased my inspiratory time and expiratory time, so that my respiratory rate came down. So at that time, I thought, when I could bring my respiratory rate down, so I can still stay back at home. I stayed back at home that night, and that night I started sweating heavily, and slowly the temperature started coming down. And since that day, slowly within 2 days' time, I was symptom free. But since then, my body was completely, I lost about 3 kilograms, 3 to 4 kgs during this time. And I was so weak that even talking I was getting short of breath. Walking one flight of stairs was short of breath. So now I'm recovering slowly, and I told that my symptom just now. This is after nearly a month now since I've been diagnosed. So more than this, I would give some few tips or suggestions which I have learned during the COVID time. These are the few things that I've done. One about food. Food-wise, I think we need to have a good nutrition. You can have lots of fruits, fresh vegetables. Your taste will go. So fruits and fresh vegetables are good. Anything hot food, spicy food, to taste better is good. And also, in South India, we take pongal, basam rice, or even the anything which tastes good and hot. That I would suggest that. Fluids very, very vital, because your temperature is so high for such a long time, you are dehydrated. We observed this even in the intensive care unit when we were treating patients, that they are dehydrated and they need a lot of fluids. So my wife, she was helping me give a lot of fluids, coconut water, diuretics, because I also had diarrhea and dysentery on top of. So having fluids every 2 hours is very important. Hygiene. Only because you are in that shell of one room, it is very important to keep yourself neat as well. So I used to have twice shower every day, just to keep yourself a little bit up. Medications wise, there are so many medications, so many trials are happening. So nothing wrong in taking them, but be careful. Hydroxychloroquine and azathioprine I've taken, just because even though I know the complications of hydroxychloroquine and azathioprine, and both in combination can produce prolonged QTC syndrome. So, but still I've taken them because I've taken them in the past. So I don't know whether it has helped me or not. I don't know, but I've taken them. Apart from this, the more important ones are your immune boosters, zinc, vitamin C, vitamin D. These are very, very, very useful. And you should take them regularly. And I'm taking even now after post symptoms. It is very useful. I used to do, I'm a Isha member. So I used to do Isha Kriya and Surya Kriya before. Some people do Surya Namaskar, like that. It is highly impossible for you to do those things because it is very straining for you. So what I used to do is I did Om chanting. Om chanting is very easy in whatever position you can do. Om is a universal word. It is. I'm not promoting any religious thing here. Om is like Oma. So if you don't like to use, if anybody, when you suggest this, if somebody doesn't like to use Om word, if they think that it is belongs to Hindu religion, they can say Amen or Amin or whatever it is. They are all similar words. They all, I don't know which one came from which, I don't know, and I'm not going into details of that. But Amin or Omen can be used. They are all like Om. So Om chanting was very, very useful. This on top of it, I also used the incentive spirometry. That also was very useful. Coming to the psychological boosting, it is very, very, very big thing. Big aspect of the whole thing is you being a doctor. Potentially, you know what actually can happen within 15 to 20 days. Potentially, you can die in 15 days. It's not even in cancer. You have at least 6 to 7 months of time where you can prepare for things. Here, you don't have any time. You can potentially, anything can happen. So I'm not saying that I was in that state, but it can happen. And twice I had a feeling that maybe now I might go to the hospital, and then probably once from there, if you are intubated, intubation rates for us, intubated patients, 60 to 75% died, intubated patients. So talk to yourself because you are all alone there. Convince yourself that you are better than those people who are dying in the hospital, or things like that. Compare yourself with something like that. Positive reinforcement is very, very vital.
Yes.
Very important. And the protection and prevention is, even though you are positive, when food used to come to my doorstep, I used to clean, wash everything, and then put it outside. And use masks for yourself at home. As much as possible, try to be away from them until you think that you are positive, you are negative. So this is very important. Despite all these things, my wife, unfortunately, she got it, and she's suffering from the last 10 days. She's slowly getting better now. Luckily, in the female population, I think it is relatively less hard on them, and also pediatric patients also it's less hard on them. My daughter also got it. So we are 3 of us at home. So all of us we are COVID positive house now. I can only say these are the small tips I can give you, which are very, very, I think they are useful.
Thank you, Murli. You are really a Mrutyunjaya, and you have actually shown the way forward. I have no words to thank you enough. It's not very easy for somebody to come up on a live webinar to share their fight with this deadly disease. But Murli, as always, has been the brave one. He's a very simple guy, but a very strong guy, and we have seen it all. So, friends, nothing to worry. I think
one comment from my side, Dr. Shanta.
Yes.
It is to Dr. Murli Krishna. You touched our hearts, sir. It is certainly, it's a very, very, for me, it is uncontrollable. By hearing your story, I felt very, very sick. In fact, I was in tears. In fact, I was in tears. Yeah. So God bless you, sir. With all the odds at your end, you came onto our program and you addressed us. We are fortunate to have you with us. We are grateful to you on behalf of Telangana Obstetricians and Gynecologists, sir. God bless you, sir.
Yes, you have done it, Murli. And all of you are going to come out. I've already come out, so we are very proud of you. And this is a living example to all of us doctors that, yes, if something goes wrong, don't get worried. That's not the end of the story. We all will get better. Narendra Malhotra sir, don't you agree with me on this? I am sure. Thank you, Murli. I'm really sorry to keep you waiting for so long. You can just relax now.
No, how much I can take it now. So this was also a good thing to, So I know that I
tested your strength.
Yeah.
And you heard all of us also.
Very good. That's why I'm going to work on another 10 days time. So I should know my capacity as well.
Thank you.
I'm coming for dinner to your house in 6 months.
Oh, bilkul.
We will go, sir. We will.
You're always welcome, sir.
Yes. Thank you. That's it. And can I quickly go through? There are a few questions, some things, Dr. Narendra Malhotra, sir. Few of us quickly about the HCQ prophylaxis. We have heard Murli Krishna, he has taken, and we have got Narendra sir who has taken. I have taken, all of us. Then the Ayurvedic diet, BCG. It's open for all. So please, whoever can contribute, starting with Narendra Malhotra, sir.
So diet is very important, as Murli also said.
I didn't get that. Could you try again?
So diet is very important.
Can we just have your this thing? Yes, sir.
Good diet, nutritious diet is very, very important.
Something else I can help with.
Regarding Ayurvedic medicine, I believe there are trials. Government has allowed for 2 trials, but I'm going to tell all the herbal people who are claiming to have all sorts of cures, please get yourself infected. Please try that herb on yourself. If you come out alive, I'll take it. HCQ, yes. BCG vaccination, luckily, is probably working good for us. Whether to take the booster or not, I'm debating. I think this Sunday, I'm going to decide I will take a booster. It's no harm. So I don't know whether it's working. Yes, Murli, you know what is.
Yeah, regarding the Ayurvedic things, I know that Ayurvedam, if it is good, it is fine. I'll welcome it. But only thing is, we know that some of the Ayurvedic drugs have a bearing on the liver.
That's it.
During COVID, most of the liver is abnormal. Plenty of abnormal liver enzymes. Like I had raised LDH, ferritin, alkaline phosphatase, and all those things. Be careful when you are taking these medications. Unless if it is guaranteed
unless it is proven by a scientific study, controlled, double-blinded study, please don't take anything. Only take immunity boosters, yes, but don't take anything else. Don't try any other drugs.
That's what I think.
Agree. Yes.
Sir, can you hear me?
Yes.
Are you advising prophylaxis to all the healthcare workers who are working in private setups?
I am.
So already I completed my prophylaxis 1 week back.
7 weeks.
So
7
I
weeks.
made my anesthetist and other doctor colleagues to take it, but I haven't impressed upon my staff members to go for it. Few of them have taken, but can I make it compulsory for all the people? Because
you can do it. You can do it with your internal orders. 7 weeks for doctors and those who are coming in patients. 3 weeks for general population, friends, family. 3 weeks. We have done it.
For our staff, it is 7 weeks.
Yeah, even we are in our hospital.
Taking for donkey years. Even when I was a child, I used to be given a chloroquine tablet by my grandfather every Sunday. So
4 tablets at a time, sir.
I think it be a problem.
Sir, we used to take 4 tablets at a time as a child. I don't think it will have a lot of problems for our people. Advice, because it's a take-home message for all the gynecologists who are practicing in the peripheral areas. They can impress upon the healthcare workers to start prophylaxis with SCQs. Can be go up to 7 weeks. I feel it is 3 weeks is not sufficient, because as much as they are also exposed to the patients. So I advise it should be the same. It doesn't matter much for the doctor or for the nurse or for the sweeper or the ward boy. It should be the same.
All healthcare workers 7 weeks.
Yes, sir.
3 weeks is only for general people who are not coming out of the house.
Sir.
Like my family members, like my relatives, those who got nothing to do with the medical profession. For those 3 weeks, and for us, 7 weeks.
Yes, even in our hospital, we are giving it to all the residents and the staff.
In fact, yesterday I got a call from some medical company, I will not name it. Sir, we are providing azithromycin, chloroquine combination kit for all doctors for profile exercise. I said, who told you? So, please.
I don't think it is a good advice to
Try doing yoga also, all of you. Yoga, as Murli Krishna said, it's very difficult physical, but at least the pranayama, as much as you can do, it will increase
So
your...
do breathing exercise, do breathing, om chanting.
Yeah. That's very good. Yeah.
How much your body permits you can do. Yeah, you can do.
Yeah.
That's the best. That's the best.
Yeah.
So I think someone is asking whether the ultrasound probe, how should be? Yes, you can clean it with sanitizer, alcohol. The transvaginal probe can be dipped in a Sidex filled solution, wait for 20-30 minutes before doing the next clean, spray your ultrasound machine, cover your ultrasound machine with a plastic thin polythene so that the virus doesn't go in between. A lot of things can be done.
Yeah, Dr. Narasimha Reddy was talking about the ultrasound. Instead of that, a Doppler can be used for just the fetal heart.
Now because PNDT is suspended, you can see the heartbeat.
Yeah,
PNDT law has been suspended for 6 months.
Yeah, but still, I mean, if it's not the
Doppler you can use.
The Doppler can be used, but it's just you can hear the fetal heart rate. But once you put your probe on the abdomen, and not even an experienced gynecologist, even he is using or she is using for the first time, you can make so many things, madam. Because not only the fetal heart, you will say, look at the fetus, what is the presentation, how the liquor is, what about the movements. They say hardly within 30 seconds, you can make up so many things. That gives me a lot of confidence in disposing of my patients. Because that's the way I am doing it for the last few days. Because though I am doing ultrasound for quite some years, I feel it is everyone has to start it. They have to keep their ultrasound at the bedside. Because they can dispose the patient instead of keeping the patient in front of you for 15 to 20 minutes and putting your head on the abdomen and talking to her. Because that also gives a lot of confidence to the patient. Ask the patient to say, look at the fetal movements, look at the fetal heart. She will be happy and you can dispose of. And let the patient with your chamber. Afterwards only you can prescribe your prescription. So you can ask the patient to leave, then you write down your prescription.
It's really heartening to see the excellent work that you're doing, even in the periphery when you have limited resources. So here in big cities we keep complaining there's no PP, there's no this, there is no that.
Madam, say whatever you does in this whole world, even I complain, my wife complains against me, my daughter complains, I do complain against my wife. We should not yield to these complaints. Complaints are going to be there. Whatever the best way you does, complaints are going to be there because it's our consciousness, and are we doing justice as far as possible to whatever the limited resources we have we have to live up to it. That's only my message, because you can't be 100% perfect in a setup. But okay, we have to live with it.
Yes, it's brave people like you.
Not that, madam, I'm not brave. A lot of brave people are in front of me. They are doing excellent work, because with all those works only we will be able to learn what extent we can go.
Yeah. I thank Shanta for connecting us to connecting all of us. Actually, it's been a great learning for everybody. For me, in these 2 hours.
So, Dr. Reddy, your mask on, please.
Yes, sir.
Thank you, everyone.
Everyone, Dr. Mahalakshmi, your mask on, please.
Yes, please.
So here we are. We will win. We will overcome. We will beat this corona.
Yes.
Okay, sir. Thank you. Thank you.